Chapter 28, The Care of Patients with Disorders of the Upper Gastrointestinal System. Lesson 28.1, Care of Patients with Disorders of the Upper GI System, Theory Objectives. Discuss eating disorders and their management, including bariatric surgery. Compare the signs and symptoms of oral, esophageal, and stomach cancer. Illustrate the cause of GERD, or gastroesophageal reflux disease. Explain the etiology and prognosis for Barrett's esophagus. Describe the pathophysiology, means of medical diagnosis, and treatment for gastritis. Contrast the difference in the care of the patient with a nasogastric tube for decompression and the care of the patient with a feeding tube. Determine reasons why total parenteral nutrition might be prescribed for a patient and describe necessary precautions to take during administration. Clinical practice objectives. Implement a teaching plan for a patient who has GERD. Provide appropriate care for a patient with dysphagia. Plan postoperative care for a patient having gastric surgery. Demonstrate the proper care of the patient with a Salem subtube for gastric decompression. And manage a tube feeding for a patient receiving formula via a feeding tube. What is anorexia nervosa? It is a psychiatric disorder or diagnosis. It is more commonly referred to as protein malnutrition in the current age, as anorexia nervosa developed a stigma. Anorexia nervosa is a refusal to eat adequate quantities of food, so not taking in enough. These patients are in danger of starving to death. We diagnose them by interviewing them, doing a history and physical on them, and also by drawing some lab work. Treatment includes behavior modification and nutrition support. Treatment and recovery from anorexia nervosa can take months to years. Bulimia nervosa is also a psychiatric condition of the GI system. Patients with bulimia nervosa consume large quantities of food, then they induce vomiting to prevent weight gain. They may also use and abuse laxatives to reduce their weight. Anorexia and bulimia can go together. Sometimes a patient can be both anorexic and bulimic. Some patients can practice bulimia occasionally without any harm, either to reduce their weight or to reduce the pressure in their stomach from too much food during a meal. Severe fluid and electrolyte imbalances happen when bulimia nervosa is diagnosed. Patients are not taking in enough fluid or retaining enough fluid, and they're vomiting up much of their fluid content. They're not getting enough electrolytes as they are vomiting most of what they are drinking. Bulimia nervosa can cause starvation and death. Treatment includes psychotherapy, antidepressant medication, and behavior modification. Obesity. The etiology and pathology of obesity is just that there's high amount of calories and fat with a lack of exercise and an overconsumption of food. Unfortunately, obesity is very common. Obesity is officially diagnosed when a patient is greater than 20% above the ideal weight for that person's height, age, and body type. We would diagnose this patient by using a height and weight chart, doing a waist and hip circumference, and comparing their measurements to a body mass index scale, or BMI. Dietary control and exercise are the main treatments for obesity. Additionally, there are medications we can give to patients to reduce their appetite or increase their metabolism. And lastly, there's bariatric surgery. Extensive counseling and assessment is necessary to qualify for bariatric surgery. And prior to bariatric surgery, the patient must prove that they are able to modify their lifestyle and keep a very strict regimen to help them lose weight and keep the weight off. There are many different types of bariatric surgery, including a gastric restrictive surgery or a gastric sleeve, a malabsorptive bariatric surgery, and a gastric restrictive combined with a malabsorptive surgery. Pre-op for bariatric surgery includes education about risk of P and DVT formation, as well as death for obese patients. We need to encourage our patients to ambulate frequently and soon after their surgery. Additionally, we need to have discussions about diet postoperatively with bariatric patient. Typically, they are only able to consume a small amount of fluid postoperatively. So, education in the pre op care period is vital. Restrictive procedures or sleeps. There can be a gastric banding, laparoscopic adjustable gastric banding. It's a placement of an inflatable band around the fundus of the stomach. That band is inflated or deflated via subcutaneous port to change the stomach size as the patient loses weight. This band restricts the portion of the stomach to a smaller area in order to reduce the amount of stomach that needs to be filled to feel full or satiated. Vertical banded gastroplasty is where a surgeon creates a small stomach pouch by placing a vertical line of staples. The band is placed to provide an outlet to the small intestine. Here is an image of gastric bypass. They've created a new stomach pouch and an outlet to the intestines. Staple line shows the portion of the stomach that we're not using and another portion of the intestine we will not be using. Vertical banded gastroplasty. You look here, you can see the staple line and the restrictive area that's created a stomach pouch. There's a banded outlet to provide a space for food to make its way into the duodenum. And you see that large section of unused stomach. This is circumgastric banding, the esophagus, and it leads to the stomach pouch, which is a small section that's created to allow the stomach to be restricted. There's also the subcutaneous port where the air can be inflated to, to decrease the size or deflated to increase the size of the stomach pouch. Malabsorptive and combination procedures. Total gastric bypass procedures cause severe nutritional deficiencies. They are no longer recommended. We want patients to be able to absorb nutrients. We also don't want to risk dehydration. The Roux-en-Y gastric bypass limits the stomach size. Duodenum and part of the jejunum are bypassed as well, which can create a short bowel syndrome, resulting in frequent trips to the bathroom and diarrhea. It also limits the absorption of calories. Therefore, the patient is less likely to gain weight. Complications of gastric procedures. Well, first, you have the leakage of stomach contents. If you do not have a great anastomosis or your staple line is not secure, you may have some leaking. Additionally, gastric stretching may occur. Just because the stomach pouch is created does not mean that the stomach will remain that size. Stretching the stomach with overeating can still occur, and then you have an overdistended stomach. Dumping syndrome or short bowel syndrome. This is where the patient's food is going to pass more quickly through the gastrointestinal system because there is less gastrointestinal system for it to move through. And nutritional deficiencies. Many patients require iron, B12, calcium, and folate infusions or supplementation to prevent a nutritional deficiency. Stomatitis. Stomatitis is a generalized inflammation of the mouth and mucous membranes. Stoma means opening. So if we think opening at the mouth, we hear stomatitis. Signs and symptoms include pain and swelling of the oral mucosa, increased salivation or excessive dryness, severe halitosis or bad breath, and sometimes fever. Patients that undergo chemotherapy are at a high risk to develop stomatitis. Treatment of stomatitis is chiefly symptomatic. We're treating what is wrong. So if you have increased salivation, we may give an anti-secretory medication. If you have excessive dryness, we may tell you to suck on ice chips or to do mouth care prior to a procedure. If you have really bad breath, we're going to do our best to control bacteria and also to reduce the smell. And if there's fever, we're going to treat the fever and the underlying pathology. Control symptoms of stomatosis: how? Special mouth care, artificial saliva, and changes in the diet. Dysphagia. We see dysphagia a lot with strokes, also with tumors that grow in the digestive tract, esophageal diverticula or outpouchings, inflammation, or motility disorders from a neurologic disorder. Symptoms include a mild sensation that something is sticking to the throat, or anything along the entire range from that to complete inability to swallow solids or liquids. Treatment is to give semi-soft or pureed foods. Add thickener to liquids if needed. And there are different thicknesses to liquid or viscosities. You can give nectar thick, honey thick, and some facilities even have like a molasses thick, which is even thicker. And then there's also thin liquids for the people that do not have issues with dysphagia. Pureed foods can come in formed molds for patients with dysphagia, which makes them feel like they're eating a carrot or eating macaroni and cheese. Um, it will have the same physical appearance because it's molded into shape, even though it's pureed food. It's very important that patients with dysphagia see a speech pathologist so we can make sure that they're able to swallow food safely. Cancer of the oral cavity is another gastrointestinal condition that we must look at. The etiology and pathology of it is that primarily squamous cells create carcinomas. And these squamous cell carcinomas are growing inside of the mouth, and that is cancer. Oral and pharyngeal cancer risks include cigarette smoking, use of smokeless tobacco, pipe smoking, and heavy alcohol use. Signs and symptoms, sores or discolorations on the lips or in the mouth that do not heal. How do we diagnose it? Well, first, we look at it. We do a history and physical exam, and then we biopsy it. Treatment includes radiation, chemotherapy, and surgery to remove the cancer. Cancer of the esophagus. A major cause of esophageal cancer in the US is cigarette smoking. Drinking also heavily increases the risk of esophageal cancer. Esophageal cancer is the second most common cause of cancer in China. GERD causes Barrett's esophagus, which is a precancerous condition that can lead to esophageal cancer. Barrett's esophagus um, is a condition that we must be aware of so that we can treat our patients early on to prevent a continued decline in the um, integrity of the GI system or the esophagus. Okay. Signs and symptoms and diagnosis of esophageal cancer include progressive dysphagia, it just keeps getting worse, hoarseness, the regurgitation of foods, severe halitosis or foul breath, and a persistent cough. We treat esophageal cancer with esophagectomy. Nursing management includes postoperative care after the removal of the cancer and nutrition, including a consult to a dietitian. Audience response question. I will ask you this question and allow you some time to respond. When screening for the presence of risk factors for oral and pharyngeal cancers, the nurse would ask which question or questions. Select all that apply. How much alcohol do you consume? Have you had any oral lesions? Do you have family members who have cancer? What do you smoke? And have you been exposed to hepatitis virus? Take a second and form your response. The correct answer is 1 through 4. How much alcohol, any oral lesions, history of familial history of cancer, or smoking. Hiatal hernia, or also known as a diaphragmatic hernia, is another condition we will look at. Hiatal hernia is a defect in the wall of the diaphragm, and it creates a protrusion of part of the stomach or the lower part of the esophagus up into the thoracic cavity, like a loop back into the chest. Signs and symptoms of a hiatal hernia include gastric reflux. There can also be a little pain with a hiatal hernia, something to be aware of. Treatment of a hiatal hernia includes reducing the person's weight, avoiding tight-fitting clothing around the abdomen, taking antacids and H2 receptor antagonists, elevating the head of the bed on 6 to 8-inch blocks, taking proton pump inhibitors or PPIs, not eating within 3 hours of bed, and limiting the amount of alcohol, chocolate, caffeine, and fatty foods that are consumed. Lastly, it's very important to avoid smoking. Gastroesophageal reflux disease, GERD. The etiology and pathology of GERD is caused by transient relaxation of the lower esophageal sphincter, And that relaxation allows the reflux of the stomach contents into the esophagus. What does this look like? Well, the patient will experience dyspepsia or heartburn and also will be able to physically feel the reflux at times. Diet therapy, lifestyle changes, including weight loss, drug therapy, and education are our treatments for GERD. Gastroenteritis. Gastroenteritis is an inflammation of the stomach and small intestine. It is caused by food or water that's contaminated with a virus, a pathogenic bacteria, or parasites. Vomiting, diarrhea, abdominal cramping, mild abdominal tenderness, and distension may occur with gastroenteritis. One of the major causes of gastroenteritis is the norovirus. So Giardia, Shigella, and C. diff are common causes. We all know that you can smell a C. diff case down the hallway. Management of this condition includes keeping the patient in PO or nothing by mouth until their vomiting has stopped. And when they're able to tolerate it, give them fluids containing glucose and electrolytes. Gastritis is just a little bit differently. It's caused by H. pylori bacteria primarily. Other bacteria, viruses, and parasites can also cause gastritis. Drinking excessive amounts of alcohol, eating contaminated food, and acquiring an infection, using cocaine, or ingesting medications of certain types can cause gastritis as well. The pathophys of gastritis is an acute or chronic inflammation of the mucous membrane that lines the stomach, and that can cause changes in the tissue. Signs and symptoms of gastritis include anorexia, nausea, vomiting, pain, and tenderness in the stomach region. Hiccups and sometimes diarrhea may also occur. To treat gastritis, we withhold all foods that come by mouth. We administer drugs that decrease motility, and we give IV fluids for severe dehydration. Antispasmodics, antacids, H2 receptor antagonists, or PPI may also be prescribed and administered to treat gastritis. Peptic ulcers. Peptic ulcers are typically caused by H. pylori bacteria. Additionally, they may be classified as duodenal ulcers in the small intestine, or some prepyloric ulcers, gastric ulcers, and they can also be, you can have an increased risk of developing a peptic ulcer if you have, if you're experiencing tension, anxiety, or prolonged stress. Ulcers can also be caused by certain drugs and medications. Daily pattern of pain. This will be an ongoing issue in the tummy. Also, you may see some GI bleeding with a peptic ulcer. Here's an image of a peptic ulcer. Two different peptic ulcers are displayed here. The A location is a peptic ulcer located in the stomach, and the B location is a peptic ulcer located in the duodenum. Treatment of peptic ulcers includes antacids and making sure that we're treating the gastric bleeding and maybe doing a lavage with normal saline. Treating with H2 receptor antagonists, PPIs, and determining the presence of H. pylori. And if H. pylori is the culprit and the cause of the peptic ulcer, administering clarithromycin or Biaxin, plus another antibiotic, an H2 inhibitor, and a PPI. Surgical treatment of peptic ulcer may be required. Pyloroplasty with truncal or proximal gastric vagotomy may be necessary. Additionally, there may have to be a subtotal gastrectomy or gastric resection. We're reducing the size of the stomach to remove the ulcerated areas. A total gastrectomy may be indicated for severe peptic ulcer disease. Gastric cancer. The etiology of gastric cancer is that there can be a genetic trait, environmental factors, pernicious anemia, or achlorhydria that predispose the patient to the gastric cancer. Additionally, smoked, highly salted, or preserved foods may be a contributor. Typically, gastric cancer is asymptomatic. Patients may experience some indigestion, loss of appetite, nausea and vomiting, or weight loss. However, these are not always clear symptoms, and the vague um, characteristic of these symptoms may result in a slow diagnosis of gastric cancer, a delayed diagnosis. Treatment includes a surgical intervention, radiation therapy, chemo, or adjuvant therapy. Common therapies for disorders of the gastrointestinal system include decompression, enteral nutrition, and total parenteral nutrition. So, decompression is where we're placing typically an NG tube down the nose into the stomach and applying suction, usually low intermittent suction. Enteral nutrition is where we're providing a feed and total feed, like a formula feed. And total parenteral nutrition is where we're actually providing a nutrition formula through the IV. Small bore feeding tube placement. So this is an NG style feeding tube, and it shows that they are um, winding that tube through the nose, past the pharynx, down the esophagus, into the stomach, and then into the uh, upper portion of the duodenum. Here's an audience response question. I will read the question and allow pause for you to come up with your response. Regarding the care of enteral feeding tubes, which nursing behavior demonstrates the appropriate nursing care? Number one, aspirating the contents of a J tube, gentle flushing of a clogged enteral tube with 30 milliliters of water, checking for a 1-inch play on a G tube, monitoring blood urea nitrogen, prealbumin, hematocrit, electrolytes, and glucose, or rotating a jejunostomy tube 360 degrees each day. Think about your answer and form your response. The answer is 2 and 4. The appropriate nursing care with enteral feeding tubes includes gentle flushing of a clogged enteral tube with 30 milliliters of water and monitoring BUN, prealbumin, hematocrit, electrolytes, and glucose. That is the end of the chapter 28 lecture. If you have any questions, do not hesitate to speak with me, as I would love to discuss this chapter content with you.